So I've been given the opportunity to come and chat to you guys today. And I thought I'd use this platform to sort of see where, as Dr. Miao said, where we come from and where we're going in terms of managing HIV in a South African context. So in 1988, when the first World AIDS Day was held, it was the first of its kind in terms of a global health promotion initiative. HIV/AIDS was finally given the platform that it deserved, and I think this was a huge step in challenging stigma and the enormous misunderstandings that were around HIV/AIDS at the time. The reality of HIV is vastly different today than it was at that time, both in the lives of individuals and also in a healthcare perspective. And while there's no doubt that we have a long way to go in addressing HIV/AIDS in South Africa, I think that it's relevant to recognize some of the successes and celebrate these successes here at World AIDS Day. So I just was doing a bit of research and found that according to Stats SA, the percentage of AIDS-related deaths in 2006 was at an all-time high at 39.7% of all deaths in South Africa were related to HIV/AIDS. And that has dropped steadily since the rollout of ARVs in the public sector, and has dropped to a percentage of only 12.2% in 2021. So that's down from almost 40%, which is a huge, huge drop. And again, still far away to go, but we're making huge strides. And then another important thing and a massively impressive statistic is the reduction in our mother-to-child transmission, so our vertical transmission of HIV. So in 2003, we were sitting at 23%, and in 2019, that dropped to 0.7% of children being born to mothers with HIV and them actually contracting HIV. So, and this is all in the context of despite the fact that 30% of women presenting to antenatal care are actually HIV positive. So as I said, while it's important to celebrate these successes, it's also imperative that we don't become complacent in our approach to HIV/AIDS. So just for some numbers so you get an idea, in 2021, 13.7% of South Africans are living with HIV. The total number of people in 2002 was 3.8 million, and that's gone up to 8.2 million people in South Africa living with HIV in 2021. We've got the largest number of people enrolled in ART programs, and this is a huge thing that you need to understand. Almost 1/4 of South African women in their reproductive ages are living with HIV. That last statistic, I feel like, is often thrown around, and we don't really think about the implications and the gravity of that situation. That's almost 1/4 of our females in South Africa are living with HIV. And in sub-Saharan Africa, 6 in every 7 new HIV infections in adolescents are women, and girls accounted for 63% of all new HIV infections in 2021. So with this in mind, I'd like to sort of reiterate Dr. Mayalo said about the UN AIDS theme for World AIDS Day this year, which is equalize. The organization should suggest that this is a call to action for all of us around the world to actively work towards addressing inequalities that result in barriers to managing HIV. So in their mission statement, UN AIDS suggests that there is inadequate uptake of preventative methods in addressing HIV/AIDS, but particularly among young women in our most affected countries in Africa. So preventative measures include health education, access to condoms, and pre-exposure prophylaxis, and amongst other things which I'll address a bit later. So historically, we've been focusing on key populations that may benefit from pre-exposure prophylaxis, and that's changed a bit recently. So while initially we would only sort of talk about either the key populations as men who have sex with men, IV drug users, prisoners, transgender people, and sex workers, the Department of Health guidelines actually in 2020 suggested that that group is widened. So the people who will benefit from pre-exposure prophylaxis ARVs also includes adolescent girls and young women, people with more than one sexual partner, people who self-identify as being at risk, and people with a history of STI, so sexually transmitted infection, and then your people who are living in serodiscordant couples. So someone has HIV and the partner does not, and if that person with HIV is not virally controlled. So as members of South African society, and as well as healthcare providers, we should be shifting our mindset when it comes to who we're providing and who we're offering pre-exposure prophylaxis to, because we're severely underutilizing the concept of pre-exposure prophylaxis as an effective preventative method. When used correctly, the ARV can decrease the risk of contracting HIV by 99%. So this being said, the landscape of pre-exposure prophylaxis is changing in South Africa. This is in the form of a new injectable pre-exposure prophylaxis drug called carbotegravir. So this works the same as dolutegravir in that it's an integrase inhibitor, and it can be used either as treatment or prophylaxis. So this drug's already been approved in America, and there is a suggestion that it'll be rolled out in South Africa from 2023, with the focus being on providing it to young women and girls in our primary care setting, which is actually really a huge step forward that we could be taking to preventing further spread of HIV. And then what other ways we can prevent the spread of HIV? Essentially, how do we keep our negative population negative? As already mentioned, your health promotion education, condom use, pre-exposure prophylaxis, as well as routine screening and testing as we're providing here today. Male circumcision is a huge factor in preventing transmission. Our mother to PMTCT programs preventing mother to child transmission, and then very importantly is ensuring virological suppression in patients with HIV/AIDS. With HIV. So, you know, if I've maybe lost you with stats and my rambling about health promotion, I just want to press one really important thing, is that undetectable is untransmissible. So in patients who have HIV, if the viral load is LDL, which means lower than detectable, they cannot sort of, according to the science and stats, they shouldn't be able to transfer HIV to another person. So this is really important. Essentially, you can have people with HIV having healthy and fruitful relationships and healthy and fruitful lives, and while not putting themselves or others at risk. So this challenges sort of the stigma initially that HIV is some kind of death sentence, or that it sort of ends people's lives as they know it. So I'm not going to talk too much about our ARV regimens, because we're going to have our pharmacological colleagues addressing that a bit later today. But I just do want to emphasize that our improvements in the ARVs that we have access to is making a huge difference in the way that we're able to manage HIV. So our current first line, we're using tenofovir, lamivudine, and dolutegravir as one single pill. And this has made huge differences, because dolutegravir is really contributing to a lot of benefits in our management of HIV. It essentially has a higher barrier to resistance. It's got faster suppression of the virus. It has fewer interactions with our hormonal contraception, so that's very important again in our highest risk group of young women of reproductive age. And it's form of a single pill that can be taken once a day. These are things that weren't even conceived of, you know, in the early days of ARVs. So while recognizing our progress that we've made on a national level, I think it's really important to look inwards at Cecilia Makiwane and the initiatives that we've been taking and that we have in place to manage HIV. And so, and I can promise you that although Dr. Usimi did ask me to speak today, she played no role in the content of this speech. I'm receiving no monetary compensation. But so please allow me to speak to the amazing work of the Wellness Center, the HIV Center attached to Ward 5. So as interns, we rotate through the center for 2 weeks at a time. And I would say that for most of us, if not all of us, it's the first time that we have access to such comprehensive, up-to-date, evidence-based HIV care. Patients who are lucky enough to access the ARV clinic are given a real chance to have a thorough and comprehensive and personalized approach to their treatment. So we're having many patients who are on primary and secondary, on first and second line treatment who are failing regimens for many years, were never able to gain control over the virus, and having these tailor-made third line treatments. This is not access to care that we are often seeing in other areas. So of course, while the aim is not to have patients be controlled on first line in the first place, the fact that the ARV unit is able to really tackle some very complicated cases has been quite inspiring. And I think that the impact of such meticulous ARV care in the context of preventing resistance really is important to recognize when we think about, you know, every day we're dealing with patients with HIV and their ARVs, and the impact that our sort of ARV stewardship is having on the rest of South Africa. If we can prevent resistance in our patients, then we are preventing the spread of resistant HIV in the rest of the community. So there really is a greater, like a large scale difference that we can be making. And so I just want to thank you, Dr. Usimi Fuentes, Dr. Muller, and the entire team at the Wellness Center for just how much and sort of providing the service that they do, and also just providing junior doctors with an amazing background of information to go into the world with. And then sort of to kind of close off, I'd just like to take a brief moment to thank everyone here today that's going to be giving their presentations and their invaluable contributions to today, as well as to healthcare and our joint effort in treating HIV holistically. So as healthcare providers, we perform the frontline personnel in tackling HIV as an epidemic, and we're far more effective as a multidisciplinary team than we would be as an isolated role player or department. So this leads me to my next talking point, which is holistic care of persons living with HIV. So as alluded to earlier, with ARVs becoming so accessible, effective, and tolerable, our AIDS-related deaths are dropping. Patients are living well into their 5th, 6th, 7th decades. And we now need to consider that people with HIV, people living with HIV, are dealing with other kinds of diseases as well. These are all non-communicable diseases. So looking at blood pressure problems and diabetes, and dyslipidemia, and this whole range of things that we're dealing with now contributes to our what we call our quadruple burden of disease in South Africa. So the quadruple burden of disease we look at is our maternal, newborn, and child health, our HIV, AIDS, and TB, our non-communicable diseases, and then our violence and injury. So all 4 of those things can be relevant to one individual, one patient. So we have to have a holistic approach. So the things that we look at, and that's some of the things that we're going to be providing today in terms of our screening programs, are look at blood pressure monitoring in these patients, our random and fasting glucose checks, our lipid profiles, and then, obviously more relevant to HIV would then be our pap smears because of the risk of cervical cancer in women living with HIV, as well as looking actively for TB and opportunistic infections. So as I mentioned today, we'll be providing some of the screening programs, testing for HIV, our blood pressure checks, sugar checks, weight and BMI and waist circumference. These are all important. And so I think as healthcare providers, just to end off, I'd like to mention that we cannot show up for our patients and our loved ones if we're not showing up for ourselves and for our own health and our own well-being. So this means being proactive about looking after our health, and I think that's the big message that we can pass on from today. So thank you very much.